upload the first talk, which is on optimizing lung cancer staging with EBUS. For the purpose of this talk, the EBUS refers to linear EBUS only. In this talk, I will talk briefly about the current staging classification and the staging methods and tools that are in use, and then the role of EBUS in nodal and tumor staging. Currently, the 8th edition of TNM staging is in use since 2017. The major changes in this classification were in the T categories and the M categories of the lung cancer. There were no changes in the nodal categories from the previous edition. The importance of accurate staging cannot be understated because it is the most important tool that predicts the prognosis and helps identify the right treatment strategy and hopefully identifying the early stage disease which can be treated, which can be given a curative treatment. So traditionally, the tools that are in use for staging are CT, PET-CT, and mediastinoscopy, out of which CT scan remains the best choice to assess the T factor of the tumor. There are limitations of CT scan when evaluating the tumor invasion, and in terms of the lymph node assessment, the traditional criteria for the lymph node enlargement is more than 10 millimeter in size on CT scan, which is called enlarged. So we know from the evidence that the pooled sensitivity and specificity of CT for identifying mediastinal lymph node metastasis is not great. It's about 50% sensitivity and about 85% the specificity. The PET-CT scan is another tool which is commonly used for the staging methods. Again, for the T factors, the studies show that it offers better results than PET or CT alone. But again, in terms of tumor invasion, there is limited role in characterization of invasion. It does increase the diagnostic accuracy for assessment of nodal status. The sensitivity improves to about 81% and specificity to about 80%. But we have to beware of the false positive results in case of infection and inflammation, where the enlarged nodes may be benign, and there are some cases where the small nodes may contain metastasis. This Cochrane review from I think it's from 2016 that evaluated the accuracy of PET-CT scanning in determining N2 and N3 nodal status in non-small cell lung cancer. And although it had a pooled sensitivity of about 0.8, where it concluded that it was insufficient to allow management of lung cancer based on PET-CT alone. And this review included studies that had varied results in between the studies because of the country of origin, and also because of the percentage of participants having adenocarcinoma. And we know that adenocarcinoma are less FDG avid. And this is very relevant to us because we know that a large proportion of our patients have adenocarcinoma and their nodes may not be as FDG avid as we think. And then comes the traditional old surgical mediastinoscopy, cervical mediastinoscopy for upper mediastinal lymph nodes, with the average sensitivity of about 80% with high negative predictive value. But it cannot access stations 5, 6, 7, posterior, 8, or 9, where you need the left anterior mediastinoscopy, and both of these procedures, as you know, are fairly invasive. And that's where comes the EBUS TBNA, which is, as we know, minimally invasive, has a good safety profile, and we get live view of lymph nodes that we are sampling and assessing. And as you can see from this chart, the EBUS TBNA, when combined with EUS TBNA, completes the mediastinal staging except for station 5 and 6. And this is a huge advantage because with the minimal invasion, you can assess the whole mediastinum. The value of EBUS TBNA is very well established. We have a large body of evidence to prove its efficacy and the quality of sensitivity and specificity. This data shows that the EBUS TBNA is superior to mediastinoscopy when assessing mediastinal staging of clinical node 1 to 3 in non-small cell lung cancer. This shows that the sensitivity of EBUS TBNA is significantly better than mediastinoscopy, and so is the accuracy. And part of it is because all the lymph nodes are not accessible from the mediastinoscopy as compared to the EBUS. This data pooled all the studies that were published between 2006 and 2012, and that shows that the combined or pooled sensitivity of EBUS for mediastinal nodal staging is about 89%, with specificity and positive predictive value of 100% and very good negative predictive value of 91%. So we can utilize EBUS for staging of peripheral tumors, for N2, N3 staging, for T4 staging, which I'll talk about, and then we can even benefit further if we use a combined approach of EUS and EBUS. So I'll talk about this one by one. So in terms of peripheral tumors, the current guidelines suggest that for all the suspected or proven non-small cell lung cancer that do not have any mediastinal involvement on CT or PET-CT, they should have EBUS TBNA performed if there are one of these three conditions: that there is a peripheral tumor which is less than 3 centimeter, and there is ipsilateral hilar node. And even if the mediastinum is normal, it is recommended that you do EBUS TBNA staging. Then if you have a peripheral tumor and which is not FDG avid but a normal mediastinum looking, you still it is recommended that you do EBUS TBNA staging. And then if you have a tumor which is peripheral, is more than 3 centimeter, regardless of the FDG uptake, it is recommended that you do EBUS TBNA staging. And the reason for this is that there is 6 to 30% risk of mediastinal metastasis in these cases, which may not be detected by CT or PET-CT alone. But in cases where there is a peripheral tumor less than 3 centimeter and normal looking mediastinum and hilar nodes, then the guidelines suggest that the further therapy can be initiated without the need for further mediastinal staging. And it is because that there is less than 6% risk of mediastinal metastasis in these cases. Similarly, when we utilize EBUS for N2 and N3 staging, it is very important because these are the patients who can sometimes be borderline between curative and palliative intent treatment. So we do our best to try and find those patients who can be treated with curative intent or in some cases can be referred to surgery. And as we know, when we are staging for N3, N2 disease, we start sampling the highest nodal station from N3 and then move downwards to N2 and N1 stations. Again, this is a very popular study that was published, which was a randomized controlled trial, and that compared the good old surgical staging with the combined approach of endosonography staging and surgical staging, and it showed that the combined approach had significantly better sensitivity of 94% with very good negative predictive value. But this study also showed that the sensitivity of the combined EBUS and EUS alone without subsequent surgical staging was 85%, which is pretty good. And this, since this study was published, the guidelines on the management of lung cancer have undergone major revision, and now the endosonography staging is a preferred method for staging lung cancer and preferred over the surgical techniques. And because it is less invasive, it's fairly accurate and leads to fewer thoracotomies. Currently, there is another trial running which will hopefully answer this question more definitely, whether the confirmatory mediastinoscopy or surgical staging is required after the negative endosonography. And the primary outcome measure of this non-inferiority trial will be the unforeseen end to disease. So it is nearly finished recruiting, and hopefully we will hear about this trial in the near future. And then comes the utility of EBUS in T4 staging. As such, we know that the patients with suspected mediastinal or vascular tumor invasion are still at risk for futile thoracotomies or missed surgical opportunities. And the accurate preoperative assessment of the mediastinal tumor invasion is very challenging. We know from the evidence that the CT chest is of limited value, with the reported sensitivities varying from 40 to 84% and specificities varying from 57 to 94%. And the FDG PET alone offers minimal additional information due to its poor spatial resolution. So that's where we can utilize EBUS for T4 staging in those doubtful cases as well. And the image first on the top left corner is showing a tumor along the arch of the aorta, but you can see there is a distinct margin. Is there a pointer I can use? So there is a distinct margin between the tumor and the arch of the aorta here. But the corresponding image, the EBUS image, shows intact intimal layer and the tumor underneath and the aorta. But on this image here shows a tumor which is invading into the arch of aorta, and the corresponding image for the EBUS showing loss of intimal layer of the aorta. So this was a very good study published from Netherlands, from a very large EBUS center, and they evaluated the diagnostic accuracy of EBUS for assessing mediastinal and large vessel invasion, that is T4 status. And they showed that if you use CT and EBUS combined for the T4 staging, that the sensitivity of getting the T4 status increases to 91%, with good specificity of about 77% and accuracy of 82%. So they concluded that both EBUS and CT alone are not sufficient enough for the T4 status assessment, but if they are used in combination, then a negative EBUS with a negative CT may rule out T4 status with high certainty. And then in the last part of my talk, I will talk about the single scope approach, which is combined EUS and EBUS. So EUSB is a term which is used for the an EBUS bronchoscope in the esophagus, and it gives the advantage that we can access station 8 and 9 along with the left adrenal gland and liver mets, so to complete mediastinal staging. We have a growing body of evidence to support single scope approach. This meta-analysis from 2016 showed that the EUS and EBUS combined significantly improved sensitivity in detecting mediastinal nodal metastasis, therefore reducing the need for staging surgical procedures. So the current guidelines now suggest and recommend that for mediastinal nodal staging, the combination of single scope approach is preferred over the either test alone. These forest plots from the studies pooled and showed that when you use the combined approach using EBUS and EUS alone, or EBUS in the esophagus, then it definitely increases the sensitivity between 13 to 21%, which is a huge advantage. And that brings me to the end of my presentation with the take-home messages that what we all know already, that the accurate staging is key to optimal treatment strategy. EBUS is a very useful tool for complete mediastinal staging, especially when combined with the EUSB, and it can also help in T4 staging in those doubtful cases, and that is the area that I think we need to practice more and more and utilize this, and it remains a very minimally invasive and a quick procedure in expert hands. Thank you very much.